Welcome to our lesson on procedural integrity versus treatment fidelity. This is original BCBA exam practice, not official BACB exam content. We will first build the concept distinction, then work through 15 scenario questions. The point is not to memorize two labels. It is to find the relation that controls the decision in the exact stem. Our free BCBA mock exam is waiting on screen. Why spend time on this pair? Because a poor client outcome does not tell you whether the treatment is ineffective until you know whether the treatment was delivered as written. These 15 items move from component-level implementation data to staff performance, adaptation, measurement, ethics, and database decisions. They train you to separate procedural delivery, broader treatment fidelity, client effectiveness, social validity, and competence limits. That prevents the common error of replacing treatment before repairing drift or treating one implementation score as proof of client success. The payoff is a defensible next action that protects the inference and the client. This is a focused concept plus questions lesson, not a complete review of every task in the published outline. First ask, was the plan delivered as written? Procedural integrity and treatment fidelity are often used as overlapping labels. The STEM's measurement target decides the best answer. Implementation evidence comes before a treatment verdict. Did each program component occur? Was the sequence and dosage followed? Can observations verify implementation? Is implementation consistent enough to interpret? Were adaptations documented and justified? Does outcome evidence support modification? Outcome data need an implementation bridge. A weak outcome is ambiguous when a critical treatment component is missing. Repair the bridge before interpreting the destination. Plan to find observable components, observe sample actual delivery, repair train, coach, and recheck drift interpret, then judge effectiveness. A percentage is only as useful as its denominator. The BCBA must select a measurement procedure that represents the procedural components and the decision being made. Measure implementation, client outcome, and social validity as related but separate questions. Question: was the step delivered? Did the client change? Unit component / opportunity target behavior / outcome source, direct integrity observation, client outcome data, separate. Check implementation drift, social validity / acceptability trap. One global score hides drift outcome alone proves too much. A good plan can look ineffective when delivery drifts. Do not replace a function-based intervention until you know whether the program relation was implemented. A treatment can be sound, poorly delivered, or both. Staff deliver the prompt. The alternative response was reinforced. The program consequence followed. The client's target behavior changed. The change maintained or generalized. The intervention remains socially valid. Staff behavior and client behavior are two data sets. A BCBA can improve staff accuracy without yet proving client benefit. Staff improvement is not the same as client success. Define observable staff component, measure opportunity by opportunity, delivery, coach model, rehearse, and give feedback, retest, check staff and client outcomes separately. Adaptations need a reason and a record. Flexible delivery can preserve treatment fidelity when the active relation and safety boundaries remain clear. Adaptation is not drift when the active component is protected and monitored. Core keep the function-based relation, adapt, change format for access or context document record, what changed and why, verify, recheck integrity and outcome. Use the decision path the STEM gives you. The answer changes depending on whether the missing evidence is implementation, outcome, competence, or acceptability. Choose the next defensible action, not the loudest action. Drift found, repair, and coach delivery, sound, analyze client data, outcome weak, check function, and design risk / limit escalate safely and document. The distractors skip a necessary evidence step. Many options are reasonable actions, but not the first action supported by the STEM. The best answer protects the inference before escalating treatment. Poor outcome is not equal to poor plan delivery, may be incomplete. More intensity is not equal to more fidelity. Adding steps does not repair drift. Acceptability is not equal to implementation. A liked plan can still be delivered incorrectly. Staff score is not equal to client change. Keep the data sets distinct. Repair first, then interpret and modify. Before the first question, use 4 passes. Isolate the clue that changes the decision. Name the relation, history, measure, implementation issue, or sequence being tested. Test every option against that clue, rejecting any answer that adds missing evidence or solves a different problem. Then state the portable rule in your own words. We will read the complete stem and all 4 options, pause before the reveal, announce the correct answer once, and explain every distractor in relation to this exact case. Question 1. A function-based intervention has not reduced aggression after 2 weeks. Direct observation shows that staff often skip the programmed communication reinforcement step. What should the BCBA do first? A. Measure and repair procedural integrity before concluding that the intervention is ineffective. B. Replace the intervention immediately because the outcome is poor. C. Increase the treatment intensity without checking implementation. D. Ask the client whether the intervention seems scientifically valid. Pause and name the decisive relation before you choose. Choose A. Measure and repair procedural integrity before concluding that the intervention is ineffective. The observed implementation is missing a program component that is central to the intervention. The outcome cannot be interpreted as a treatment failure until the BCBA checks and repairs whether the plan was implemented as written. The trap is that a poor outcome does not prove a poor treatment when the treatment was not delivered as written. B. Replacing treatment skips the unresolved implementation problem. C. More intensity does not solve a missing component and could increase risk. D. Acceptability is relevant, but does not answer whether the intervention was delivered correctly. When outcome data are weak and implementation is drifting, verify and repair integrity before judging effectiveness. Question 2. A BCBA wants to know whether staff deliver each step of a token procedure during observed sessions. Which measure best targets procedural integrity? A. A parent satisfaction rating after the session. B. A component-level checklist scored during direct observation. C. The learner's overall behavior change graph alone. D. A staff member's estimate of how often the plan was followed. Hold the labels for a moment. Match the evidence to the options. The strongest answer is B. A component-level checklist scored during direct observation. The decision concerns whether each prescribed implementation step occurred during sessions. A direct component-level checklist measures adherence to the procedure itself rather than satisfaction, outcome, or memory. The trap is that outcome data can coexist with implementation errors. They're not a substitute for an integrity measure. A. Satisfaction does not show whether the token steps were delivered accurately. C. The learner's outcome cannot reveal which implementation component was skipped. D. Self-estimate is less direct and may miss component-level drift. Measure procedural integrity with direct, component-level evidence when the question is whether steps occurred. Question 3. A team compares whether an intervention is delivered consistently by 3 staff members across home, school, and community sessions. Which measurement target is most directly described? A. Social validity of the intervention goal. B. Treatment effectiveness for the learner. C. Treatment fidelity across implementers and settings. D. The learner's response generalization. Choose the answer that the exact stem supports, not the one that sounds most familiar. On this stem, select C. Treatment fidelity across implementers and settings. The team is examining consistency of implementation across people and contexts. The broader cross-implementer and cross-setting consistency question is treatment fidelity. The learner outcome is a separate variable. The trap is that the term fidelity is about implementation consistency here, not about the size of the learner's behavior change. A. Social validity concerns importance, acceptability, and value, not implementation consistency. B. Effectiveness asks what changed for the learner, not whether staff delivered the plan consistently. D. Response generalization concerns learner responses across stimuli, not staff implementation. When the comparison spans implementers, settings, and sessions, look for a treatment fidelity question. Question 4. Direct observation shows that staff implement 96% of the intervention components across sessions, but the learner's target behavior has not improved. What is the best next interpretation? A. Implementation must be low because the learner did not improve. B. The staff need immediate retraining on every intervention step. C. The intervention is effective because fidelity is high. D. Implementation is documented as high, so evaluate intervention effectiveness and fit separately. Before the reveal, ask what the STEM proves and what it leaves unknown. The evidence supports D. Implementation is documented as high, so evaluate intervention effectiveness and fit separately. The integrity data are high while the learner outcome remains weak. High fidelity removes one rival explanation, but does not prove the intervention is effective. Effectiveness and contextual fit must be evaluated separately. The trap is that fidelity is a condition for interpreting effectiveness, not evidence that effectiveness already occurred. A. The direct observation contradicts the claim that implementation must be low. B. Retraining every step is not indicated when fidelity is already high. C. High fidelity shows implementation, not a guaranteed behavior change effect. High integrity supports interpretation of an intervention test, but it never guarantees a positive outcome. Question 5. A supervisor wants to decide whether a technician follows a written prompting procedure. Which evidence is strongest for the immediate decision? A. Direct observation scored with the written component checklist. B. The technician's belief that the procedure is easy. C. A learner rating of how friendly the technician is. D. A higher learner score on a different skill. Take a second pass. What must be true for each option to win? This question resolves to A. Direct observation scored with the written component checklist. The question asks whether the technician performed specified steps, so direct step-level observation is the closest evidence. The checklist links the observed behavior to the written procedure and allows the supervisor to identify exactly where drift occurs. The trap is that a positive outcome or positive impression can coexist with procedural drift. B. Ease of use is not evidence that the technician followed the steps. C. Friendliness is a social variable, not a measure of procedural adherence. D. A different skill outcome cannot identify whether this prompting procedure was followed. Match the measurement method to the implementation decision. Direct step-level observation is strongest for procedural adherence. Question 6. A staff member delivers the token board, but never provides the programmed exchange for the selected reinforcer. Which conclusion is most defensible? A. Fidelity is adequate because the board was present. B. Procedural integrity is compromised because a functionally critical component is missing. C. Treatment effectiveness is established because tokens were visible. D. Social validity is low because the staff member used a token board. Pause and name the decisive relation before you choose. Choose B. Procedural integrity is compromised because a functionally critical component is missing. The programmed exchange step was omitted, so the written contingency was not delivered as designed. A visible token board does not establish integrity when the component that makes tokens exchangeable for the programmed reinforcer is missing. The trap is that count the functionally important step, not just the presence of the materials. A. Presence of materials does not show that the complete procedure was implemented. C. Tokens being visible cannot establish a learner outcome or treatment effect. D. The STEM describes implementation drift, not a social validity judgment. One omitted component can invalidate procedural integrity when that component changes the program relation. Question 7. A fidelity checklist shows that staff often deliver the instruction but omit the programmed feedback statement. What is the best initial performance management response? A. Assume the omission is harmless because the learner still responds. B. Replace the entire intervention without observing again. C. Give specific feedback, model the missing step, rehearse it, and remeasure. D. Increase the learner's reinforcement before training staff. Hold the labels for a moment. Match the evidence to the options. The strongest answer is C. Give specific feedback, model the missing step, rehearse it, and remeasure. The checklist identifies a specific, teachable implementation error. Specific feedback plus model, rehearsal, and follow-up measurement directly targets the observed staff behavior. The trap is that the best next step is often a targeted implementation repair, not a new treatment. A learner response does not prove the omitted feedback is irrelevant to the written plan. B. Replacing treatment ignores a correctable performance problem. D. Changing learner reinforcement does not teach staff to deliver the missing feedback step. When integrity data identify a specific staff behavior, train the behavior with feedback and rehearsal, then check it again. Question 8. An aggregate fidelity score is 88%, but one staff member implements 99% of components and 2 others implement about 70%. What should the BCBA examine next? A. Only the aggregate score because staff differences average out. B. The learner's preference for the highest scoring staff member. C. Whether the intervention should be stopped for everyone. D. Component and implemental level patterns that the aggregate score hides. Choose the answer that the exact stem supports, not the one that sounds most familiar. On this stem, select D. Component and implemental level patterns that the aggregate score hides. The same average masks a large difference in implementation across staff. Disaggregating by implementer and component reveals where fidelity is failing and supports targeted support. The trap is that a respectable average can still contain a clinically important low-fidelity subgroup. A. Averages can conceal the exact staff pattern that needs intervention. B. Preference does not explain which implementation components are drifting. C. Stopping treatment is premature before understanding and repairing the fidelity pattern. Disaggregate fidelity data when an aggregate score hides meaningful implementer or component differences. We are halfway. Notice how the questions now separate implementation data from client outcomes, staff performance, adaptation, and the order of professional decisions. If you missed one, name whether you skipped an integrity check, used the wrong denominator, or escalated before repairing a current constraint. Question 9. A team intentionally changes the reinforcement interval after a contextual fit review, documents the new plan, and trains staff on the change. How should fidelity be evaluated? A. Against the documented, approved adaptation rather than the retired version. B. Against the original plan forever, because any change is drift. C. Only by the learner's outcome after the change. D. Not at all, because adaptation makes fidelity impossible. Before the reveal, ask what the stem proves and what it leaves unknown. The evidence supports A. Against the documented, approved adaptation rather than the retired version. The team formally changed and documented the intervention before training staff. Once an approved adaptation becomes the active plan, fidelity asks whether staff implement that current plan accurately. The trap is that plan change and unplanned drift are not the same implementation event. B. A documented, approved change is not automatically implementation drift. C. Outcome data cannot replace implementation measurement. D. Adaptation changes the fidelity target. It does not eliminate the need to measure it. Measure fidelity against the current documented intervention plan, including approved adaptations. Question 10. A caregiver reports that an intervention is acceptable and important, but direct observation shows that staff omit 2 written steps. Which conclusion is justified? A. The intervention has high procedural integrity because it is acceptable. B. Acceptability and implementation are separate. The omitted steps indicate an integrity problem. C. The learner's progress proves the omitted steps do not matter. D. The caregiver's report should replace direct observation. Take a second pass. What must be true for each option to win? This question resolves to be, acceptability and implementation are separate. The omitted steps indicate an integrity problem. The caregiver's rating addresses acceptability, while observation shows missing implementation steps. Social validity and procedural integrity answer different questions and can produce different results in the same case. The trap is that a plan can be valued by stakeholders and still be implemented inaccurately. A. Acceptability does not demonstrate that staff followed the written procedure. C. An outcome cannot erase direct evidence that steps were omitted. D. Caregiver report may add context but cannot replace direct implementation data for this decision. Keep acceptability and implementation evidence separate. One does not substitute for the other. Question 11. A BCBA wants procedural integrity data that represent typical implementation across busy weekday sessions. Which design is strongest? A. Observe one unusually quiet session chosen by the staff. B. Ask staff to estimate their average performance at the end of the month. C. Sample direct observations across typical staff, sessions, and relevant components. D. Use only the learner's monthly outcome graph. Pause and name the decisive relation before you choose. Choose C. Sample direct observations across typical staff, sessions, and relevant components. The goal is representative implementation data under the environmental conditions that matter. Sampling typical sessions, staff, and components provides a more defensible estimate than one selected session, self-report, or learner outcome alone. The trap is that a precise score from an unrepresentative session can still mislead the decision. A hand-picked quiet session may not represent routine implementation demands. B. Estimates can miss component-level errors and are not direct evidence. D. Learner outcome does not identify how or when staff implemented the plan. Representative integrity data must sample the people, sessions, components, and constraints relevant to implementation. Question 12. A treatment outcome is poor, but the case contains no direct implementation observations and only informal staff comments. What is the best next step? A. Conclude that the treatment is ineffective from the poor outcome. B. Add a punishment procedure immediately. C. Stop collecting outcome data until the learner improves. D. Obtain direct procedural integrity data before interpreting the outcome. Hold the labels for a moment. Match the evidence to the options. The strongest answer is D. Obtain direct procedural integrity data before interpreting the outcome. Implementation status is unknown because the case lacks direct integrity evidence. Without knowing whether the intervention was delivered, the BCBA cannot distinguish treatment failure from implementation failure. The trap is that unknown fidelity is not the same as low fidelity, but both require better implementation evidence. A. Poor outcome alone cannot separate ineffective treatment from low integrity. B. Adding punishment skips the missing implementation diagnosis and may increase risk. C. Outcome collection remains useful. The missing step is implementation measurement. When outcome is poor and fidelity is unknown, measure implementation before making an effectiveness decision. Question 13. A team implements an intervention with high fidelity in the clinic, but the learner's skill does not occur at home. What question should the BCBA examine next? A. Whether implementation and relevant cues differ across settings. B. Whether clinic fidelity data should be discarded. C. Whether high fidelity guarantees generalization. D. Whether the caregiver's preference proves the intervention failed. Choose the answer that the exact stem supports, not the one that sounds most familiar. On this stem, select A. Whether implementation and relevant cues differ across settings. Fidelity is high in one setting, while the skill fails to generalize to another. The next analysis should compare implementation, cues, materials, and reinforcement across the clinic and home rather than treating clinic fidelity as a guarantee of transfer. The trap is that implementation integrity and learner generalization are related but separate data questions. B. Clinic fidelity remains useful evidence. It does not need to be discarded. C. High fidelity in one setting does not guarantee generalization across settings. D. Preference is relevant to contextual fit, but does not by itself prove treatment failure. High fidelity is setting-specific evidence. Compare implementation and stimulus conditions when transfer fails. Question 14. A staff training package is delivered with 95% fidelity, while the learner's target behavior changes only slightly. Which statement is most accurate? A. The staff training package must have been implemented poorly. B. Implementation fidelity and learner treatment outcome should be evaluated as separate relations. C. The learner's small change proves the staff were not competent. D. The fidelity score should be replaced with a satisfaction survey. Before the reveal, ask what the STEM proves and what it leaves unknown. The evidence supports B. Implementation fidelity and learner treatment outcome should be evaluated as separate relations. The staff training implementation score and the learner outcome are different data streams. A high implementation score supports confidence about delivery, but the learner outcome still requires its own effectiveness analysis. The trap is that high fidelity protects the inference but does not decide the outcome by itself. A. The 95% score does not support the claim that implementation must have been poor. C. A small learner change cannot establish staff incompetence when implementation is high. D. Satisfaction does not answer either implementation or effectiveness. Do not turn an implementation score into an outcome conclusion. Analyze each relation with its own evidence. Question 15. A BCBA learns that implementation varies across staff and that the outcome is weak. Which initial plan best fits the evidence? A. Retrain everyone on the entire intervention without identifying the drift. B. Replace the intervention before collecting any more data. C. Use a component-level checklist, observe the drift, provide targeted feedback and rehearsal, then reassess. D. Ignore the implementation data and increase the learner's workload. Take a second pass. What must be true for each option to win? This question resolves to C. Use a component-level checklist, observe the drift, provide targeted feedback and rehearsal, then reassess. The STEM identifies variable implementation, so the first plan should locate and repair the specific performance gap. A targeted integrity cycle links observation to feedback, rehearsal, and reassessment without changing treatment prematurely. The trap is that the best first action is evidence repair, not a broad treatment change. A. Retraining every step wastes information about which component is actually drifting. B. Replacing treatment before repairing implementation confounds the inference. D. Ignoring integrity data removes the evidence needed for a defensible next step. When implementation varies, locate the component drift, train the behavior, and reassess before replacing the intervention. Across these 15 questions, the durable move is to protect the inference. Measure whether the programmed components occurred, repair drift, separate staff performance from client outcome, and only then interpret effectiveness or modify treatment. Procedural integrity and treatment fidelity may overlap in ordinary language, but the STEM's measurement target and next decision determine the best answer. If this lesson helped, keep practicing with our free BCBA mock exam for time questions. Then use our quick study guide to review the relation behind each miss. The links are shown on screen. Subscribe, share the item that made you pause, and return for the next lesson. We are building a clearer BCBA exam library, one deciding detail at a time. Use our quick study guide for a slower pass through the definitions, contrasts, examples, and exam traps from this lesson. The complete guide link is shown on screen, and the free BCBA mock exam is ready when you want to test transfer. We are building a clearer study routine together.